And this is one of the top questions that I get. Who is the problem new to? The sheet actually state in there established problem to examiner, new workup to examiner. So this does mean, was that physician familiar with the patient's condition before this? Did they treat it? Now, when we think about that in practical terms, then we have these kind of broader issues. Does that mean that what if somebody in the same group practice, in the same specialty, saw that patient for the same problem? Well, that examiner still has to go through the reviewing of the history, looking at the patient's notes, figuring out where the patient is in that. So it is still considered new to that examiner. So you really do want to take this very literally. It's to the examiner. So going back to our ENT example, the problem is new to that provider. And so the increased score for a new problem, whether 3 for no additional workup plan or 4 for additional workup plan, is given because working up a new problem involves more work than assessing a problem that's established or familiar to the physician. The catch is that not all problems are scored based solely on new or established to the examiner. You alternately have to consider if the problem is self-limited or minor. So here we have our self-limited or minor category, and then after that we've got the established problem, new problem, or new problem. Don't skip down and look at these until you find out if you're ruling out the self-limited or minor, because if you're self-limited or minor, the established versus new doesn't end up applying. The table of risks lists a cold as well as an insect bite and tinea corporis, which is a superficial dermatophyte infection, as examples of medical conditions that are considered a self-limited or minor problem. For cases involving a self-limited or minor problem, even if the condition is new to the examiner, you still count the problem status as self-limited or minor and assign it the 1 point, as I was showing you, instead of giving it the 3 points for being new to the examiner, or however many it would be for an established one. So how do we decide what a self-limited or minor problem is? CPT defines a self-limited or minor problem as a problem that runs a specific course, is transient in nature, and is not likely to permanently alter health status or has a good prognosis with management compliance. So clearly this is the case with something like a common cold, like a 460, which is self-limiting, a virus that affects the upper respiratory tract. As the CMS guidelines state, the assessment of risk of the presenting problem is based on the risk related to the disease process anticipated between the present encounter and the next one. So risk measures the chance of the patient becoming worse from the time he leaves the physician's care to the next visit. A common cold carries minimal risk, consistent with the definition of a minor or self-limited problem. Be sure to check if the patient has pre-existing comorbidities that affect the treatment of the current condition. This could be something like diabetes or asthma that has a systemic impact on the patient. When a pre-existing comorbidity is addressed and affects the patient's care, encourage your physicians to include the underlying diagnoses and not just the primary diagnosis. Doing so may potentially change the MDM level and consequently the level of the EM service. So let's look at this example. An established male patient previously diagnosed as controlled diabetic presents with complaints of a runny nose and congestion without any other symptoms, such as fever, headache, fatigue. Ignoring the comorbidities and listing only the presenting problem diagnosis, the 460, will make the visit qualify for the lowest risk level. The physician should also consider the effect the patient's diabetes has on management options, and if the physician treats the condition, she should also report the 250.XX code for the diabetes appropriate specified type and controlled or uncontrolled for addressing the underlying disease. This is consistent with the documentation guidelines, which further state comorbidities, underlying diseases, or other factors that increase the complexity of medical decision-making by increasing the risk of complications, morbidity, and or mortality should be documented. So you're going to be aware and accepting of if there are other conditions that the physician has to be treating because it's going to have an impact on the medicine or the level of risk, and take those into consideration. Coding the chronic condition will reflect the higher level of risk involved. So actually reporting these on your claim is going to help substantiate potentially coding a higher level. We'll also increase the diagnosis and management options element of medical decision-making from minimal, which involves one self-limited or minor problem, to a limited, which involves one self-limited or minor problem, plus one stable, previously diagnosed problem. Since the level of medical decision-making depends on meeting two of the three elements, meaning you have to meet the diagnosis management options, the amount of complexity of data to be reviewed, and the risk of complications, boosting the risk and diagnosis management options will support a higher level of medical decision-making. Okay, so going back to our previous ENT otitis media case study, we're going to look at calculating the data point. Here's an example. An ENT sees a patient with diagnosis of otitis media. This is the one that we were looking at before with trypanostomy. And let's tally the amount or complexity of data reviewed using that table. This one's fairly simple because the ENT did not review any data. He receives a 0 in this table. Remember to map your CPT codes to the areas listed in the amount and or complexity of data reviewed box. So when you're looking at our audit tool, you want to make sure that you have some kind of cheat sheet that you create, or right on here if this is the audit tool that you use, that you map out what the review and or order of tests in the radiology section of CPT, medicine section, clinical lab tests, which codes these map to. And that's because you're going to give a point for clinical lab tests, things like urinalysis or strep test. So these are your 80,000 series codes. Radiology tests, like an X-ray or CT scan, would fall under the 70,000 series. And don't miss, the table counts medicine tests, those are your 90,000 codes, in a different section from an X-ray or the EKG section. So if the physician reviews an X-ray and orders an ECG, you could give a point for each of these tests, because you'd have your X-ray in your radiology section. If you also were doing something like an ENG, which is on our medicine section, then you would be able to get your 2 points because you would have your radiology, your X-ray one, and then you would also have your ENG in your medicine, so you could get 1 point for each of those. I had a few questions about this area today, and the main thing that I want to emphasize is that you don't double dip. So if the physician is coding the service, like an X-ray, and let's say allergy testing in our medicine section, he would be getting credit if he was the reviewer and not actually billing that code. You give the diagnostic procedure points for work the physician could not otherwise get credit for, such as a strep test that an outside lab is reading or an X-ray that an outside radiologist reads. But if you're actually getting credit for the radiology tests and interpretation using the radiology code or the ECG code, whatever kind of code you're doing, then you would be counting that interpretation as part of the professional component of that CPT code. So you would be billing that test, and therefore you would not then be giving credit under the EM section as well.